So Matt had to hit record real quick to start getting some. We had the baseball smack happening here in the beginning of the show. Chad, as the audience well knows, is a Dodgers fan. I'm a Yankees fan. Our guest, Tim Blasl, outed himself willingly. We didn't have to beat it out of him or anything. Admitted to being a Boston Red Sox fan, Tim.
Yeah. Now, it's so cute, you guys waiting for spring training. I mean, some teams are still playing this year.
Yeah. Well, if only our governor was here and we could dunk on him for the Mets.
Yeah.
Collapsing towards the end of the season, as Mets are wont to do.
Yeah.
You know, it's not even that odd a thing. We didn't bring Tim on to talk about baseball, although we could. We could. And I will. Chad is so touchy and he's so mean to the Yankees. I am always such a gentleman to you about the Dodgers. I like the Dodgers team. That pitching performance last night.
Unbelievable.
Going 9 innings. Fantastic. I love Frank Freeman. I love Mookie Betts.
Yep.
I love Kike Hernandez. Is one of the great baseball personalities of our era. It's a great team. I hate it when they beat the Yankees, but I don't hate on the Dodgers.
So here's the thing. I don't like to go over the top, like with too much crap talk during the season, but I do like to do little zingers. I have a friend who's a big Brewers fan, and he was in Milwaukee for game 1, and he had really good seats. And at one point he was on national TV with his face in his hands. And I recorded the thing, and I showed him enough respect to not send it to him until the next morning because I feel like he needed a little bit of time. But baseball is a stressful, wonderful thing, and I don't think there's anything more stressful and great than October baseball when every pitch matters. It's beautiful.
It's great when you win. Breaking when you lose. I mean, there's for all that, like the controversial political topics that I navigate. I'm used to all that. I am sensitive about baseball, man.
And it hurts in a different way.
Yeah, and I was a long-suffering Red Sox fan until about 2004. So I became a Red Sox fan in the mid-'70s when they played the Big Red Machine, and so it was tough there until about 2004. It's actually been tough since about 18, but hopefully we got some young guns coming up, so hopefully we'll become competitive again here.
Hope springs eternal.
Yeah.
We bring you on to talk baseball. We brought you to talk about the cost of healthcare, which I'm sure everyone just loves talking about.
Yeah.
We actually had a couple guys. It turned into a running, for no intention of ours, kind of turned into a running topic, vitally important, and sort of spawned, obviously, by what's going on in Washington, D.C. It was a big debate over the subsidies, or premium subsidies for Obamacare, Affordable Care Act policies. You know, and our insurance commissioner, John Gottfried, you know, basically warning, if these aren't put in place, you know, it's going to be dramatic premium for a lot of North Dakotans, a lot of Americans. That's the insurance side of things. You represent the care side of things. It's the hospitals, you guys employ the doctors, you provide the care, we get sick. And obviously, you know, part of what, when we talked to our insurance commissioner, John Gottfried, he referred to kind of a finger pointing match between the insurers and the care providers over cost. The insurance industry wants to blame the hospitals want to blame the insurance industry. My argument is Americans are scared. North Dakotans are scared to go to the doctor. You know, when one of my kids gets sick, that's the first, I mean, as a dad, I mean, obviously I'm concerned about their well-being first and foremost, but I'll tell you, like 1A on my priority list is, what is this going to cost me? I am terrified to take my kids to the doctor because I don't know what the bill's going to be. How do we navigate that right now? I mean, I think we had a guest on last week, Chris Jones. I know you said you listened to the interview. You know, one of the things he's talking about is like price transparency. I think that makes a lot of sense, but how do we get our hands around these costs, Tim?
Yeah, no, I mean, it's a great question, and it is a huge concern. You know, we get into price transparency, you know, there is a CMS requirement for that now. And so hospitals are required to post their charges online, and also it's all their services, and then also I think their most common shoppable services. And so, but I don't believe that's going to bend the cost curve. You know, again, I think we need to define, you know, prices versus costs. You know, again, you know, prices, yes, there's a charge that we charge, obviously, the patients that come through the door. What I want you to understand is that typically we don't collect those charges I would say 90 to 93% of our payments that we receive, whether it's from the federal government and CMS or state Medicaid or commercial, those have been sort of predetermined already. So even though we have a charge, we are not collecting what we charge. Again, that cost for the consumer. And I agree. I mean, healthcare is expensive, and it's expensive for the consumer. It's expensive for the provider. But again, when in terms of hospitals and physicians, again, if one hospital charges, and again, I'm going to try to make this simple, but if one hospital charges 1,000, the next one charges 2,000, that cost to the consumer for the most part, if you have insurance, is going to be the same. So again, for us, in terms of we spend a lot of time talking prices. Typically, hospitals don't collect prices. We do have to establish a charge. But again, if you have insurance in this country, you are not paying what that charge is. You're paying that part of that negotiated rate that's been determined between the payer and the provider. And again, I agree with Chris Jones in his statement last week, or I think he mentioned it once or twice, that healthcare is complex and it is expensive. And I know that my members, the association, we're trying to spend time talking about how do we reduce costs. We can talk price transparency, but how do we focus in on the cost piece? And what should healthcare look like? Now, I have some of my own thoughts, but again, that's what we got to focus in on. So again, patients shouldn't be concerned about. And I get it; it's expensive, and I know we have some people that are focused in on what it's going to cost. I mean, I have a family; I'm concerned about that as well. So, but I just want to be kind of transparent in terms of you hear all these discussions on hospital prices. Typically, we do not collect what we charge.
So, Tim, one of the things, I mean, if you've listened to any of the recent podcasts, you know that I'm frustrated with the cost of healthcare and health insurance. And part of me as a consumer and somebody who's in charge of employer that pays for health insurance for 25 of our employees. And I represent teachers who are negotiating health insurance, which is the biggest cost in the district. I hear you, I hear the insurance companies, and sometimes I hear what seems like you guys are just trying to protect your business model. That is working because that's what we sort of do. And, to hear it's complicated. Yup, it's complicated. That doesn't help me. That doesn't help me as a consumer. Why can't the hospital association and the insurance companies sit together? Because it does feel like, no, it's their fault. It's their fault. Here's the deal. I think the hospitals have a role. I think health insurance companies have a role. And I think Congress has a big ass role in this thing. And at the end of the day, those three groups are making decisions and the consumers are being hurt. Yeah. So how do we move the ball forward? If it's not more transparency, how do we move that ball forward? So we're thinking about when Rob takes his kids to the hospital, he's thinking about just about his kids' well-being, not about what that check is going to look like when he has to write it.
Yeah. No, I think you're absolutely right. I think communication, getting together is key. I think, one nice thing that we started in the state here last interim session was the healthcare committee. It brought together, hospitals, it brought together physicians, it brought together the payers. And again, whether it was, Blue Cross here in the state or the Sanford Health Plan, it brought together legislators to start, having those discussions on what we can do, at least in the state. And so, those are some great discussions. In terms of, we had a lot of discussion about, how do we prevent, I think the big piece, in my mind, if you're going to change healthcare and try to reduce costs, I think is preventative services before it becomes chronic. I think that's one avenue. I think end of life is the big one. But again, just, my experience in terms of bringing people together, that's what we were doing last session. I think those discussions need to continue. But yeah, no, I agree with you. I think, to fix this and make it better, all the players, and when I say players, that are hospitals, physicians, you got payers, you got big pharma, you got the pharmacy benefit managers, the PBMs, all of that. We all have a part in this, and yeah, we shouldn't be doing any finger pointing at all. Again, we're in this all together, but to kind of fix this and talk about costs. I mean, you have to get people in a room and have that discussion. And again, I have to commend or, the legislators it was I think it was the 23-25 session, when we talked about this in terms of bringing a committee together to start those discussions. So again, I think that was a kind of moving in the right direction. But no, totally agree with you that again we need to bring people together to work on this.
One of the pushback I got from some people who work in your industry after our interview with John Gottfried, and I followed up with an independent column based on some of the information he had shared with us, where his office had a secret shopper go around and found some pretty wild price disparities between Minot and Fargo and Bismarck and Grand Forks for pretty routine. I think it was a C-section birth, a birth, and a colonoscopy. And just why it costs 300% more, 600% more, whatever the differential was from, I think it's really hard to understand. That sounds to me like a situation where prices are completely disconnected from reality. And then there's also the fact, I think a lot of people have experienced this. I mean, I've looked at my parents' itemized medical bills. I've looked at my itemized medical bills. I see like a tab of aspirin costs $65 or something like that. And that, again, that just seems like is not tethered to reality. So can you speak to that? Because I got a lot of people saying that the secret shopper thing specifically was not a valid metric. And maybe you addressed that somewhat where you said, because, we're negotiating with the government through their various programs. We're negotiating with the insurers through their various programs. A lot of times the price that gets paid for covered people is not the price. So maybe that renders this moot. But I don't know. Speak to that secret shop.
Yeah, you bet, Rob. Again, there's been some national stories done on this. Obviously I'm very familiar with the study, the health study that the insurance commissioner, did, I want to say maybe 5-6 years ago, and where there was some price shopping going on. Now, will prices be different? Yes. I think what people need to remember, and again, and maybe the insurance commissioner did ask these questions, but typically, again, before I've been at the Hospital Association here for about 17 years, but I used to be in the provider setting. And so I know how things work in terms of, revenue and things like that. Now, again, when people price shop and, again, hospitals have been providing prices to consumers for years. I mean, this is not something new, but again, let's just say I'm going to use an example, like back to your C-section. You're going to have that individual, that female is going to come to the hospital. There's going to be a physician involved. There's probably an anesthesiologist involved. There could be a radiologist involved. And all those services are billed separately to insurance companies. They're not all on one claim. And so when you do some price shopping, you need to make sure that you're comparing apples and apples. And so if I come into, I'm just going to utilize Sanford Health here in Bismarck, and you call on, hey, what is the normal charge for a vaginal? Okay, they're going to give you a price quote. Okay, well, we need to make sure that includes all those other players involved. So if Sanford Health does, and I'm just going to throw out a number, if that is 10,000 and now you call Altru, and you just get the hospital component, it is going to be a lot less. So when you do some of that shopping, you have to make sure that you're asking the right questions. I'm not saying that the insurance commissioner's office did not do that. But again, when I see those kinds of differences, Rob, those are some of the questions I have to make sure that when we're doing some of that shopping, we're making sure we're asking the right questions and we're comparing apples to apples.
That's fair. I don't know. I don't know the methodology for that.
Yeah. Just kind of going
because I guess that makes sense, where if you ask Trinity Hospital in Minot, which is where I go, and well, how much for a knee replacement? And they quote you a price, but they don't include the anesthesiologist or the radio or all those other specialists. I guess that makes sense. But why are they all billed separately? Because when I go to Trinity, the radiologist works for Trinity, the anesthesiologist works for Trinity, and that thing, when I'm trying to sort out how much a thing costs me, and I have like 5 bills from 5 different divisions of Trinity, and it's like, why can't I get one bill?
Yeah, no, it's a requirement. So again, when we go and bill the insurance companies, though there's separate claim forms for those different types of services. And so, yes, I mean, I'll give you an example. Back in the day, I used to work at a bigger health system here in North Dakota, and we did not employ our own, say, cardiologist. We didn't employ our own anesthesiologist. But if you came in for a procedure and each of those individuals touched on that care, those separate groups would bill separately. It is confusing to the patient. It is, because they're getting bills from, two or three other individuals or groups. And so when you do your price shopping, you got to be asking the right questions and making sure that you're capturing everything. So again, like I said, back to my example, you may call Sanford here in Bismarck and they may give you a bundled price. You may call another hospital and they may unbundle that, if that makes any sense. So I think when I see those big variations in terms of price shopping, that's the first thing that comes to my mind, that did one hospital bundle and the other one didn't. So you just got to be, and like I said, I know those differences. I've seen those differences that the insurance commissioner had in his report. And I'm not saying they're wrong. I'm not saying that at all. But I'm just saying, with those kind of differences, those are questions that, pop up in my brain.
Again, I worry about the consumer in this whole thing. I mean, Tim, you mentioned several times there, you got to know to ask the right question. There's no way a consumer is going to know to ask the right question at every one of these hospitals. I wish the healthcare providers would just all use the same system when they're telling people what they're paying for. But that's not my question. I want to talk about financial transparency. Obviously, the insurance companies have to provide the insurance commissioner with their financials when they're looking for rate increases and that kind of things. One of the things that John Godfrey talked about on the show is that we don't see that same level of financial transparency from hospitals. I mean, I know that hospitals do their 990s, but it's not necessarily an individual hospital. It's more of the big system. And as our systems are getting bigger, it's even more difficult to figure that out. So how can we figure out like what we can do if one side of this equation has to provide all their financial information, and then the healthcare system has a different way of reporting that financial information? They have to dig through and sort of figure things out. It just doesn't feel like, if we're not comparing the same things, that we can figure out. Again, we don't want to point fingers,
No,
but
you're
we
right.
need to have the data to make decisions on what's going on here.
Yeah. Again, in terms of within the state having a requirement to provide that information, right now there is not that requirement. Now, again, we work with our members to pull a lot of that financial information and, provide that, during a legislative session, things like that. But I also want to point out that, you mentioned the 990, but also each hospital that participates in the Medicare program has to fill out a Medicare cost report every year, and that is public information. And so that information can be, requested through the Freedom of Information Act. But every year, hospitals have to put together a cost report, which again consists of all their revenue, all their contractual allowances, all the discounts that they take from either patients or provider or payers, all their cost components, all their financial information is required by Medicare. So a lot of that information is public today. There's probably not a lot of people that are aware of it, but a lot of this information does get published through different consultants, throughout the country. So there is a big, huge document that hospitals have to put together every year to provide this information to the federal government.
Tim, you said the state doesn't currently require this. Should the state require this?
Well, that's something we're working on. Again, I'm not saying it's shouldn't be required, but it's something we're working on here at the association to sort of create a database to have all this information gathered and, obviously supply it to, individuals that, legislators, things like that, different committees that would want to see it. So again, there is, and again, and I think that in a lot of other states, it's probably not a requirement. But again, there is no formal process right now in terms of supplying financial information to HHS, things like that. I think a lot of times they're using 990 and Medicare cost reports to get to that information.
Sorry, Rob, one more. But so, Tim, you're telling me that the hospitals have this information. So if the state required it to be brought to the state, they have that information already. So it shouldn't be too big a burden for hospitals to provide that information to the state.
I think the state would have to do a little bit of digging to get to it. Again, they would have to, file a request to get to, say, a Medicare cost report. Again, it's not a requirement today in terms of a state requirement. If it was, we would comply, but, that's
But I
not
guess,
in place today.
Tim, my question is, if the state were to require it, what I'm hearing you say is that the hospitals already put this information together for other things, so it wouldn't be a big burden on individual hospitals to put together this information to provide to the state if it were required.
Correct.
Okay.
Yep.
I wonder, I mean, we talk so much about price transparency, and I do think that's important. I think when you see prices spiraling the way they have, and certainly when you have a situation, I mean, there's some pretty famous charts about inflation for things, and like higher ed's obviously way up there, but number one are healthcare costs.
Yeah.
Which I mean some of it's, we can do more stuff medically, right? It's not a doctor showing up at your house with a black bag anymore. I mean, it's very complex, and all those medicines and technologies cost money, both in terms of developing the technologies and buying the machines and training to use them appropriately. So I get it, and that's driving some of it. But I wonder if price is everything in this, because when we talk about, okay, well, the government has all this data and people can go look at this data, but when someone's really sick, they're just going to go to the hospital. I live in Minot. I think there's a couple other clinics or whatever, but for the most part, if it's a serious thing, I have one place I can go. Plus I'm willing to drive to like Bismarck or Fargo or something.
Right.
And so, I mean, I think price transparency is only going to get us so far. From the hospital side, you said you guys are interested in or looking into driving down prices. What are your ideas? I mean, what do we need to do to get prices lower?
Yeah, again, it's that's a great question, Rob. Again, I kind of go back to what we experience in the hospital setting. Again, I think the major driver that's increased, again, whether it's the last 10 years, are pharmaceuticals. It is, we have these great drugs that come out. Well, there's a price tag on those, and it's expensive. And I think, outside of probably, just to kind of give you an idea, is that in terms of hospital expenses, I would say roughly 60% of those is related to salaries. The other component, are supplies, and obviously pharmaceuticals are one of those supplies. I think if we could get some sort of, I don't want to call them caps, or get our arms around the increase in the pharmaceutical business, I think would help drive down costs. And so I think that would be I think where I would want to start in terms of trying to bend that cost curve. Because again, price transparency is, and again, this is my personal opinion. There is a CMS requirement today. The state wanted to make it a requirement, back in the last session. And that we felt was just another layer because it mirrored what the federal government was doing.
Representative Jared Hendricks' bill.
Yes. And, again, we totally support price transparency. We support,
Well, I was going to ask, what was the specific argument against that legislation?
Because it was mirroring what CMS requires us to do today. So if you look at what that bill required hospitals to do, it's the same thing as what CMS requires us to do today. And that is, having available to the consumer a list of all our prices. And, there's, the federal government audits hospitals, there's civil penalties. And at the end of the day, the state, again, Representative Hendricks's bill would have done the same thing. So we just felt like it's a federal requirement now. Why should we be spending state dollars to monitor it on the state level when the feds do it already?
Tim, one of the things that I think all North Dakotans should be concerned about is access to rural hospitals, right? I mean, one of the real quality of life things that we have in the state is making sure that you can access healthcare. And I think, people don't talk enough about Can-Do and some of these other places that are really providing great services, but it's really expensive to also do those things. And one of my concerns not concerns, but one of the things that, we had during Obamacare, we had the Frontier Amendment, right, to take care of rural hospitals. And now during the big ugly bill, in my opinion, some people call it a beautiful bill, there's a big chunk of money again for rural hospitals to protect them. I worry that when we do these carve outs to get people's votes or whatever, It's not, it just makes the whole system more complicated. So recognizing we need rural hospitals, but also I'm not sure that's the best way to do legislation. Can you just comment a little bit on sort of these federal programs that help protect our rural hospitals and that type of thing?
Yeah, again, at the end of the day, especially in the rural areas, they want to keep access to care in those communities because typically, in those rural communities, the biggest employers are typically hospitals and, the school.
Yep.
And so I think Medicare did a great thing probably about 25, 30 years ago when they created a provider type, which is called critical access hospitals. Okay. And so the funding or the reimbursement for those services is different than urban hospitals. It really is almost kind of covering 100% of their costs. There's a few things carved out, but it allowed, these hospitals in rural communities to remain open. I'm very optimistic in terms of the funding that came out of the One Big Beautiful Bill or just the One Big Bill in terms of the Rural Health Transformation funding program. Now that is being, discussed here in Bismarck. It was discussed yesterday and today. I'm going to go up there this afternoon. But how is that money going to get distributed within the state? And so I think, in terms of getting some funding into the state to help rural communities is critical. So, we have roughly about, in terms of general acute care hospitals, about 36 smaller hospitals in the state. We haven't had any closures like other states. I think, back with the ACA and us expanding Medicaid really helped keep some of those doors open in the rural communities. But, again, I think some of the things that have been with the critical access hospital provider type being created has really kept the doors open in a lot of these rural communities. So, and again, when decisions are being made in Washington, because we're working with our congressional leaders all the time. So what makes sense for Texas or California or New York, a lot of times doesn't make sense for North Dakota or, us frontier states. And so we need to keep our legislators, our congressional leaders up to date on that. And, sometimes those decisions in Washington don't make sense for us. And so we try to keep we monitor that very closely.
That seems to be a lot of what our delegation does when it comes to federal insurance or healthcare policy is to try to get carve outs for North Dakota to excuse from it because, and I'm sure that's not unique. I'm sure Ohio has challenges in Illinois and Texas and Missouri, and they all have different challenges that are specific to their states or their regions that make this difficult. This is a tough thing, the price thing. And again, I think at the end of the day, I mean, I think there's a lot of people who feel like I do where they're scared to go to the doctor because they're scared of the bill. Yeah. And that's a terrible place for Americans to be in. I mean, I think in a lot of ways, one place where your industry should be commended is I think we have the best healthcare in the world. Yeah. There are people who travel from around the world to come to the United States to enjoy the innovations that we have and the expertise. There are people who want to be doctors who travel from around the world to want to be doctors in America. Yeah. The innovation and the expertise is. That's a great, not to look down our nose at the great things happening in other countries, but America's a leader in this area. And that's
yeah, and I agree with you, Rob. And I think we can be proud of the healthcare we're providing in the state of North Dakota. Yes, there is, a price tag on that. It's not cheap. But, again, we provide great quality healthcare here in the state. And, and my members are, want to keep healthcare local. They're doing whatever they can to keep, again, I'll just use, I just got off the phone with the CEO in Grafton. And so he's doing everything where he can keep that local community coming to his hospital instead of having to travel, whether it's to a Grand Forks, Fargo, or Minneapolis. And so, again, I think we're providing great health care in the state. I think you can, travel anywhere in the state and get great care. So, but yeah, I mean, it is not cheap. But, again, I think when I talk to people a lot, we take a lot of calls, again, somebody was in, they got an itemized bill. Why is the charge so high? I try to educate them that, again, a lot of times, in terms of what you're trying to determine on what it's going to cost you, is, working with your insurance company. I think our uninsured rate here in North Dakota is roughly 8 to 10%. We're very fortunate. It's higher in other states. And so again, when you get into the hospital finance piece of things, is that, yes, there is that charge, but again, hospitals in terms of their budgets have to work within, probably 90 to 93% of their payments fixed. And so again, when they're doing, yes, there is the charge, but we don't actually get paid that charge. We get paid from the insurance company.
Does that explain why some of the oddball, like some things that are, because the price is fixed on certain things, they make it up on other things? Like maybe that's why aspirin costs $65 a pill or whatever.
Well, Rob, I would really like to see an itemized statement where there's a drug, an aspirin or whatever that costs $65, because, again, if I'm not aware of anybody charging 65, but again, we are sensitive to, again, if you can buy it over the counter, then the price should be somewhat in that ballpark or maybe a little higher. Again, the thing is that I get asked a lot, well, why does, back to your example, for a pharmaceutical item, I can get it downtown for $1, but I go into the hospital and it's $25. There's a lot of the direct cost is the actual purchase of that drug, but there's a lot of indirects that go into the pricing of it. Again, we're open 24/7, 365, things like that. There's a lot of indirects that go into the increase in that charge. But like I said, again, if we're sensitive to that because, hospitals aren't, buying pharmaceutical items, CT scanners, and marking prices up 500%. That's not how it works. Again, we could do that, but at the end of the day, we're not going to collect that dollar amount because I'll just use Blue Cross Blue Shield. If there's a CT procedure and what's been negotiated between Blue Cross and the hospital is, say we're charging 500, but the negotiated rate is 200. That what we're collecting from both Blue Cross and the patient is $200. That $300 is just getting discounted. So again, I think people need to understand how hospital finance works. Yes, there is a charge, but the charge typically is not what is collected.
What last question, and I mean this puts you on the hot seat a little bit, but increasingly we're seeing where healthcare providers are also the insurers. And I got to tell you, I'm worried about that vertical integration because I don't know that I want my doctor to also work for my insurance company. And I know the people that are doing it, Sanford's the big one in our region. I know what their argument is, that there's a bright line between these two. And maybe you'll forgive me if I'm not persuaded that that's necessarily true in practice. But what do you think? I mean, that seems like that vertical integration seems like an emerging thing in your industry. Is that good? Is that going to solve this, or is this going to make everything worse?
That's a great question, which I don't think I have an answer to. I think, again, if it's going to reduce healthcare costs for, say, the consumer, obviously I support it. So again, it's just, I don't have a lot of background to answer that question. I'm not trying to dodge your question at all. I mean, it's tough to answer.
Wasn't squarely on what we invited you on for, but it just it's my mind, and that's kind of what we do here on Plain Talk is very free form. I appreciate you coming on though, Tim.
No, I appreciate the invite, and again, if you want me back in the future, feel free to reach out to me.
Going anywhere?
No,
I'm kidding.
No, it's a complex issue, and I wish I had all the answers. I don't, but understand that in North Dakota, we're all trying to bend that cost curve, and how we go about doing that, I don't think it's a little bit of everything. I don't think there's this huge idea out there that's going to solve all this. I think we just need to chip away at it.
Thanks for your time.
Thanks, Tim.